Thank you, Luan. It's a pleasure to have you all here. And it's always a pleasure to talk about light chains in one way or another. I was walking in New York one day and this kid came to me and said, "Are you a light chain?" I said, "No. I'm not sure what you're asking, kid, but I'm here." So anyhow, what we're going to be talking about today is myeloma cast nephropathy. You remember that 30 years ago, we used to call myeloma cast nephropathy myeloma kidney. That's all we knew. If you had myeloma and your kidney was failing, it was a myeloma cast nephropathy, which we call myeloma kidney. And we know today that that subject has changed significantly.
Dr. Herrera?
I'm sorry.
All right.
So that concept has changed significantly with our new knowledge. And as you know, light chains are fashionable now. They were not 30 years ago when we knew very little about what light chains did in the kidney. And so with that in mind, I have always been very curious about cast in myeloma cast nephropathy, primarily because I had some difficulties. There are some cases that were extremely difficult. Where do I change this?
Okay. Yeah.
Over here.
Okay.
That
You
would-
can use it now.
Oh, I can use it.
Yes.
Okay, so I have no disclosures. So we know that renal disease is very common in myeloma. We know that patients with myeloma today, the most common lesion that we see in those patients is not myeloma cast nephropathy, it's actually AL amyloid. More importantly, we're not going to see a lot of myeloma cast nephropathy going forward because we're not going to biopsy those patients. We have a test, we have the serum test for kappa and lambda light chains. We create a ratio. If that ratio is more than 100, the nephrologists are saying this is myeloma cast nephropathy until proven otherwise. It doesn't need a biopsy. So we're going to see less and less of these cases. But I think they are really trying to identify that indeed they are monoclonal casts and that indeed the patient has myeloma. So the reason today is that the cases we get today usually are patients who present older than 50 years of age in acute kidney injury. And the nephrologist gets the patient. He doesn't have the results of the special testing. There is no indication that the patient has a monoclonal gammopathy. Therefore, they do a biopsy. There you get the case. And what history do you get? Acute kidney injury, which means you know nothing about the patient. And it is your duty to look at the biopsy and try to tell the nephrologist, hey, this acute kidney injury is due to myeloma. So we use a number of techniques, as you know. And in the case of light chains, it has become very popular to do epitope retrieval. I don't know of anybody who's using epitope retrieval to diagnose myeloma cast nephropathy, and I don't know if that has any use about that at all. Now, why is it so difficult to diagnose? It's because the light chains are all different. There are not two light chains that are the same. And the antibodies we use to detect those light chains may miss a light chain or may confuse a light chain. Therefore, that creates some issues, as you will see in a minute. So what did I do? I decided to get together with somebody who had a lot of cases, and that was Dr. Truong and the Methodist Hospital. And then we decided to look at 23 cases of myeloma cast nephropathy proven and compare those with cast that occur in patients with a number of other different entities to see if we could find some things that would tell us those myeloma casts, even though they may not be monoclonal on immunofluorescence, they are myeloma cast nephropathy cast. And what are the features that we normally follow? Well, there are certain light microscopy features that we follow to consider the possibility of a myeloma cast. The presence of those cast in tubules that appear usually dilated, and these tubules can have quite reactive cells surrounding them, where the cast, because that cast is a foreign protein, and the tubular cells react to it. And then we have a multinucleated giant cell reaction sometimes surrounding those casts, when the cast goes right into the interstitium and creates a multinucleated giant cell reaction. But even the tubular cells lining the cast are going to look big and atypical because they are reacting to a foreign protein. And you can see this picture here, which you probably look at, and you will say, that is myeloma cast nephropathy until proven otherwise. However, I would feel a lot better if I get a kappa and light chain that confirms that, meaning if I can prove monoclonality or isotypicality. And the one thing that we trust for many years were those fracture planes that you can see there. And that was trusted to a point where it was excessive. And you'll see why I mean that's the case. Why is this not changing now? Oh, there we go. And sometimes we're lucky. We may see crystalline structures in the light microscopy, but that's very seldom. In my experience, extremely seldom. Or you may see, for example, in that silver stain section, some very complex cast appearance. I call it the jigsaw puzzle appearance. But most of the time, you just don't have that. So you don't have diagnostic features that allow you to make it.
Okay, there we go.
So, all right. This is going to work now.
Yeah, sometimes the Zoom overrides the keyboard.
So again, if you see the crystalline inclusions in cast, you're going to be almost absolutely sure that that's what you're dealing with. So what is the problem? Is the immunofluorescence sometimes. Now, remember, if the cast occur acutely, it's going to show the monoclonal protein. So you're going to be able to prove isotypicality or monoclonality. But if there has been deposition of a light chain, that is the pertinent light chain, and on top of that, because of a chronic situation, has been deposited the other light chain, then that monotypicality is not going to be present. That's going to make your diagnosis difficult, especially if your light microscopy is a little atypical. So what happens if you look at the immunofluorescence in those cases? Notice here that of the 23 cases that we saw, if we would look at the immuno and use isotypicality as a diagnostic feature, only 10 of the 23, we could say for sure there were myeloma cast nephropathy cases. And 3 we said consistent with because there were findings that were quite suggestive that that was the case. Only found isotypicality in 50% of myeloma cast nephropathy cases. And interesting enough, if you see this picture, for example, is that myeloma cast or not? You can guess because I don't know for sure if it is or not. If you see this picture now with inflammatory infiltrate, with the atypical big cells lining the cast, and with the changes you see there, perhaps a couple of fracture planes, you start thinking that may be the case. This is the typical situation. This is case number 1. This is a 67-year-old male with AKI, no monoclonal workup available at the time of the biopsy. But there you can see it's definitely a kappa light chain related myeloma cast nephropathy. Nobody has any problems with that case. I hope so. Okay, so that would be the kind of case that you would look at it, you would be certain. And then here again, lambda is totally negative. However, only the myeloma cast will be the ones negative. There are some casts that are positive. Those happen to be other casts that are present in this biopsy. So you don't look at every cast in the biopsy. You look at the ones that look like myeloma casts and see if they're positive or negative. And so we went ahead and studied those 23 cases. They were looked at by 4 nephropathologists, and they were very carefully examined ultrastructurally. Notice again the fracture planes, how beautiful they are. Notice again the inflammatory infiltrate. Notice that some of the casts contain inflammatory cells, all the features of myeloma cast nephropathy. What about this case? This is the second case. Same thing, 57-year-old female with monoclonal gammopathy, IgG kappa. So have a little clue there in the history. But listen, I can't say that's isotypical. I can't say that's monoclonal. I can't say for sure this is myeloma cast, even though there are some of the features of that cast. And remember that this is going to be colocalized with tan-horsfall protein in every case. So what were those features that we identified? By the way, we looked at this case as double blind. So I was looking at cases of myeloma, cases that were not myeloma, and I was taking notes of what I was seeing. And there were 3 pictures that we saw in the ones that belong in patients with myeloma cast nephropathy. And we got it right in every case but 1. And the 3 cases with the 3 things we identified as being specifics were crystals. And I'm talking about crystals like the ones you see in Fanconi syndrome or in the proximal tubulopathy with crystalline inclusions. I'm talking about those specific crystals. I'm talking about cases in which there were amyloid fibrils. And going back, we would do a Congo red stain and we would prove that. And I'm talking most important about cases that had the jigsaw puzzle arrangement of the tubular cast contents. Some cases looked like that. And those casts were not present in every tubule. You had to look around for a while to find the typical cast. And you can see some of them are electron dense, some of them are electron lucent. And this particular case, which we diagnosed, had a bone marrow biopsy 30% of clonal plasma cells. So it was myeloma in the background. Some of them had amyloid. And you use the same criteria you use in any kidney biopsy to diagnose amyloid, except that it's found in the distal tubules, as we see here. We probably have seen this for many years, but we kept it quiet. We didn't tell anybody. Not until recently, the idea of amyloid cast nephropathy has become fashionable. And then we found this casting here that had that very complex appearance of the interior contents of the cast. And that's what I call the jigsaw appearance, where there are many pieces to it, like a puzzle that is getting together, and there were the reactive tubular cells surrounding the cast. See in there, see over there, and see over there. Of all those features, those were the ones found in the majority of cases with myeloma cast nephropathy. Now, if you look around in other proximal tubules, around the cast, the one the cast has, you're going to find proximal tubules with a lysosomal component that is overactive, as you can see here, because they're trying to process those light chains that are coming into the distal tubules. So in essence, there are certain pitfalls you should keep in mind. One of them is one that Sybil addressed, and that is the presence of tan-horsfall uromodulin, because those give you fibrils, but they are perpendicular to one another. They're thicker than the typical amyloid fibrils. You don't confuse that with amyloid CAS. That's a very important point. You need to evaluate the cases carefully. You got to look at more than 1 or 2 or 3 tubules. Find several CAS that you can look at because you may find some CAS that are not myeloma CAS in the biopsy. And also make sure that you identify properly what you're looking at. This here is light chain deposits in the CAS. Means nothing because it could be the isotypical light chain, but it could be the other light chain. And you'll find that in most cases, and that doesn't mean a thing. And you should not use that as one of your criteria. Now, that is Tam-Horsfeld protein. It is perpendicular to one, parallel to one another, thicker than the typical amyloid, and it will fill the lumen, as you can see, and it could be admixed with any of the other things that I have shown you before. If you want more details, you can go to our article in Ultr structural pathology. Now, I want to show you 2 more examples that are very important. There has been a case described of tacrolimus and rapamycin giving you an appearance on light microscopy, which I'm going to show you right now, that really mimics myeloma CAS nephropathy. But in that case, both kappa and lambda were positive. Therefore, that would eliminate the possibility if you're looking at it from that point of view. Also, the vancomycin CAS could be a confusing problem too, one that we see because vancomycin is used quite often. But there is an immunostain for vancomycin, as Dr. Trump explained to you. This is a picture of the tacrolimus case. Notice that. You look at that, the multinucleated giant cell, the inflammatory component, the fracture planes. If you look at that and use that as your only criteria, you're going to give this guy amyloid. You're going to give this guy myeloma, and he doesn't have myeloma. It has nothing to do with myeloma. And the vancomycin associated is a very good article that Dr. Trump wrote. And again, you can see findings that would be suggestive, as you can see here. Notice that one, almost has the jigsaw appearance that I was mentioning, but you have the staining for vancomycin that allows you to make a definitive diagnosis. So keep in mind that electron microscopy can be extremely helpful. He also shows you the appearance of the typical CAS of vancomycin, which are quite different from the ones I have shown you. Do not trust fracture planes. You can find fracture planes in virtually any disease you want. Here you have these beautiful fracture planes on the H&E, and they are in a patient with focal segmental glomerulosclerosis. So keep in mind that if you look at those things de una manera of a manner that you carefully evaluate the situation, you're going to be able to make the diagnosis of myeloma CAS nephropathy with certainty, and the electron microscopy is going to be more useful than the immunofluorescence. There's one slide there that I missed. The majority of the CAS of myeloma CAS nephropathy are negative for IgA, and a good number of them are negative for IgM. And again, you may have a biopsy with a lot of CAS positive for everything, IgG, you can have it positive for IgM, for IgA, for kappa and lambda, but when you come to the myeloma CAS, the IgA is usually negative, 80% of our cases. IgM is often negative too. Those are clues that you're dealing with myeloma CAS. So, in essence, EM can be extremely helpful. So use it to your advantage.
Question.
Yes.
Do you